Thank you very much, and I apologize for the lateness. We were finishing up. Your executive board is working hard for you, and our meeting at lunchtime went over, so we just finished. But as I said, well, it can't start till I get here, so I guess I'm not really late. So today, I had the pleasure of introducing the concepts of intracranial and extracranial MR angiography, and it's been a true honor. I mean, I just said in the meeting that I've had the pleasure of being your treasurer for the last 4 years, and it's been a true honor to be able to give back to this society because it has given me so much, and I know all of you who continually come to this meeting really value it because of how much you get out of it. One of the things you can see is how much Neck MRA has advanced. For the young people, we actually used to do invasive catheter angiography and cause a stroke about one every 100 to 200 patients, and we were doing 200 or 400 of these a year. So we were causing strokes from our diagnostic study, and it was this field and it was this society that changed that, because we proved with non-contrast, first 2D time of flight, later 3D, that we could see what angiography could show us, but at no risk to the patient. Next step is contrast MRA. First pass became available because of research done by people at this meeting, and we showed that it was better for seeing ulcerations and length of stenosis. It was better at seeing the very slow flow distal to a very critical flow-limiting stenosis. No problems with flow saturation from a horizontally oriented vessel. So these are all great things. So one of the challenges from our last meeting is how I take that last meeting, gadolinium deposition. The challenge to all of you smart people in this room is now go backwards. All the things that I just showed you, we do better with contrast MRA. Figure out a non-contrast way to do this. And we'll have that option, and we will win a lot of patients, maybe black blood. Non-contrast MRA would be a great opportunity. Then we started adding value by moving beyond luminograms and looking at the vessel wall. So we know that if we do a T1 weighted sequence, this one's fast spin echo, but also MP RAGE, we can see intraplaque hemorrhage. And this was a great patient from when I was at Michigan State. A woman, 65-year-old woman presented, and the neurologist wasn't sure if it was a seizure or a TIA. Nothing on the brain. Ultrasound said less than 50%, but because he knew we do vessel wall imaging routinely, well, let's just see what Kevin can show us. And what we showed was an ulceration. Yes, this diameter over that's only 30%. The ultrasound was right, but they couldn't depict the ulceration, and most importantly, they couldn't depict the juxtaluminal intraplaque hemorrhage, the culprit lesion, and we changed an unknown to a known. That was the value that we added. Next, we did vessel wall imaging intracranially, and this is just outstanding work by Bruce Wasserman and others in the atherosclerotic risk in the community. The ARIS study showed in almost 2,000 walkie-talkie patients in the community, no known atherosclerotic disease, moderate, middle-aged or elderly, 1/3 of them have intracranial atherosclerosis. And we heard in this meeting the combination of plaque in your neck, plaque in your head, bad. And we can find this non-invasively. Here's another one. This patient had a full workup for figuring out where this embolic stroke was. Nothing in the heart, nothing in the neck, nothing in the carotid bifurcation, no stenosis in the middle cerebral artery, but vessel wall imaging showed us the culprit lesion with enhancing lesion, the dark T2 of a lipid-rich necrotic core, eccentric wall thickening, intracranial atherosclerosis without any kind of luminal narrowing. Again, that's the value that we've learned how to add. We've learned how to add for luminography. This patient presented, and I saw this little bump there, and I was worried about an ACOM aneurysm. And indeed, we were able to confirm that it was an inferiorly projecting anterior communicating artery aneurysm. DSA confirmed it. We still added value because when we did the volume rendering, we saw that that dome was not smooth like the MIP suggested. It was actually highly irregular with multiple outpouchings. That's because there were silent ruptures of this aneurysm. This took it to a high risk. And this person likely would have bled, and 1/3 of the people who bleed as an outpatient die before they ever get to the hospital. We were able to add that value, find it, and the neurosurgeon who did the study did some 3D rotational that showed the same thing. In fact, when he looked at my images, he said, kind of like your images better than mine. So we add a lot of value. We add a lot of value in following up aneurysms that have been coiled. This patient had exactly that scenario, bleeding aneurysm. He was the lucky 2/3 that make it to the hospital and don't die. They plugged up where it was bleeding with some coils and just a dome, but they had to leave this really big edges to the aneurysm. Here's the coil mass. The aneurysm used to be this big, and you see this really big neck here and this one right here. So I always do in my follow-ups a non-contrast time of flight. Then I do a contrast MRA, just like we do in the neck, just do it in the head, because it shows me those residual necks excellently. And then I do a post-contrast 3D-T1. So we brought the patient back for definitive surgery, who is now stable. And as you can see, the only thing that's left is this tiny little bit of a neck of an aneurysm right here, but we couldn't take this out. That's the posterior communicating artery, the only supply to the posterior cerebral in this patient. But look how much better. See the big neck here, and now we can follow this over time non-invasively. The other thing that's really exciting is venography, and we can do this with non-contrast, and so that there's decreased flow in the transverse sinuses. We can see it's decreased on this side because it's congenitally hypoplastic, and right there, there's the severe stenosis, and I really like these contrast-enhanced images, and this was the case I was referring to. We're now studying a group of patients with suspected increased pressure in the brain, not because it's a tumor, we call it pseudotumor, cerebri, and what we're looking for is those patients with focal narrowing where the pressure drop across is greater than 10 millimeters of mercury, because those are the ones that get better when they pop it open with a stent. And we're not perfect at figuring this out anatomically, so that's where we're going to add value with flow information. So as a society, we began with luminography. We then added in value with vulnerable plaque imaging, intracranial vessel wall imaging, and flow. And today we're going to excitingly hear more about intracranial flow analysis and MR evaluation of thrombus. And with that, I'd like to introduce our first speaker, Carson Hoffman, towards automated cranial 4D flow analysis. Thank you very much.